ഹായ് എവ്രിവൺ. അങ്ങനെ അവസാനം ENTയുടെ കൂടവായി. ഇത്രയും കാലം ഞങ്ങൾ എങ്ങനെ ഇതിൽ നിന്ന് രക്ഷപ്പെടുമെന്നുള്ള ഗവേഷണത്തിലായിരുന്നു. It is not because that we are reluctant to present in these forums. It's because that we have been closely following the discussions in this forum. And most often, പലപ്പോഴും നമ്മുടെ ഫിസിഷ്യൻസ് വളരെ സസ്പെൻസ്ഫുൾ ആയിട്ട് വളരെ റെയർ ആയിട്ടുള്ള ഡിസീസസ് ഒക്കെ വളരെ ഭംഗിയായിട്ട് പ്രസൻറ്റ് ചെയ്ത് കാണുമ്പോൾ അതുപോലെ തന്നെ അതിൻ്റെ കൂടെ തന്നെ പലരും അതിൻ്റെ ഇൻപുട്സും ഇൻവെസ്റ്റിഗേഷൻസ് ചെയ്യാം എന്നൊക്കെ പറയുമ്പോൾ ഞങ്ങൾ സർജൻസ് പലപ്പോഴും ഇതൊക്കെ ഞങ്ങളുടെ തലയുടെ മേലെ കൂടെയാണ് പോകുക. മോസ്റ്റ് ഓഫ് ദ തിങ്സ് ഗോ അബവ് അവർ ഹെഡ് ആൻഡ് we have most of the times we have no clue as to what is really going on. But for us surgeons the problem is entirely different. For us, diagnosis is never a dilemma. Most of them are present with the diagnosis. And our issues are when to actually, is this operable? And if it is operable, when to operate, what to operate, how to operate, when to stop, and what would be the best outcomes of such a surgery. And it's mostly the communication with the patient and the bystanders. അപ്പം ഞങ്ങൾ ഇതെല്ലാം പറഞ്ഞു കഴിഞ്ഞാൽ മോസ്റ്റ്ലി ബിക്കോസ് ഇറ്റ്സ് ENT, it's a small area. When we talk about our endoscopic surgeries, it's very likely that our colleagues may not really comprehend what we are talking about. But that is why we were slightly reluctant to present. We were thinking of what topic we would present because we would like everybody to participate. And finally we decided that we would talk on a topic which involves many departments of our hospital. And we decided to talk on invasive mucormycosis. Yeah, it's a black fungus, but we will not use the term black fungus as such because that is completely a misnomer. And also I thought that I would use this arena to introduce my team to the entire hospital. So let's go ahead.
Good evening. I am Dr. Shalini Kurian, working as a consultant in ENT and Head and Neck Surgery Department. We all know mucormycosis or black fungus hit the headlines of recently in this COVID scenario. I would like to shed some light into the etiopathogenesis of this dreadful disease. Before I go into that, I would like to say a few words about fungal sinusitis in general because the word fungal sinusitis draws fear into the mind of common people as well as in medical community. Chronic rhinosinusitis is a group of disorders characterized by inflammation of the nose and paranasal sinuses, which lasts for at least 12 weeks. Several factors influence this, one of them being fungal. Fungi are eukaryotic organisms and are omnipresent and are ubiquitous in habitable environment. Mucorales are found in decaying organic matter and are thermotolerant. Even though the fungi were identified as causative agents of diseases even before bacteria, pathogenic fungi have been received scant attention and hence the classification and treatment of fungal diseases are still under debate. Although fungi are ubiquitous, the degree to which fungal exposure occurs depends on the environment. The warm, moist climate in our geographic area and Kerala being an agriculture-based economy, there is high risk of exposure to fungus in our areas. Fungi can interact with and influence the upper respiratory tract in various fashions. In fact, microscopic fungal colonization of the mucosa of nose and paranasal sinuses can be a normal finding even in normal and disease states. When conditions supporting fungal growth are present, clinical apparent form of fungal proliferation may occur. Fungal rhinosinusitis can be broadly classified into two, invasive and non-invasive. In invasive form, fungal elements are present outside the paranasal sinuses. The distinction between invasive and non-invasive are made based on the clinical presentation, imaging evidence and histopathological confirmation. Non-invasive fungal sinusitis can be further classified into two. One is fungal balls where the immune system is neither under nor over responsive, and the second one is allergic fungal rhinosinusitis which is secondary to over responsiveness of the immune system. Invasive fungal rhinosinusitis can be classified into three: acute invasive, chronic invasive and granulomatous invasive. Acute invasive fungal rhinosinusitis occurs in patients with severe immunocompromised condition, whereas chronic invasive and granulomatous invasive is seen in patients with intact immune system. Mucormycosis comes under acute invasive fungal rhinosinusitis, also called acute fulminant or rapidly progressive fungal rhinosinusitis. Mucormycosis is a term commonly used to designate infections caused by all the species coming under the order Mucorales under the class Zygomycetes, that is Rhizopus, Mucor and Lichthemia. Rhizopus is the most common and most virulent of all of them, and it's the most acutely fatal infection known to the humans. It's rapidly growing, and even within 24 hours it can fill the top of the culture plate. Mucor has a propensity for vascular invasion and obliteration leading to ischemia. The incidence of mucormycosis has considerably increased recently as a result of widespread use of antimetabolites, antibiotics and steroids. The fungi are normally virulent but are able to invade the tissue when the general resistance is extremely low. The primary infection occurs in the upper respiratory tract or nose where the spores germinate, and then the mycelia invade the adjacent tissues, the orbit, the sinuses and the brain. Most human infection result from the inhalation of spores that are released into the air or by direct inoculation into the diseased mucosa or skin. The most important predisposing conditions are malignant hematologic conditions with or without stem cell transplantation, prolonged and severe neutropenia, diabetes mellitus with or without diabetic ketoacidosis, iron overload conditions like thalassemia, sideroblastic anemia, etc., major trauma, prolonged use of corticosteroids, illicit intravenous drug use, neonatal prematurity, malnourishment. Antifungals with no activity against zygomycetes such as voriconazole and caspofungin, they can cause breakthrough zygomycosis. Nosocomial mucormycosis has been associated with exposure to heavy fungal loads which may be due to construction work, contaminated air filters, procedures and devices such as contaminated wound dressings, catheters, tongue depressors and even allopurinol pills. The growth of mucor is facilitated by acidotic conditions and as the fungus grows, it facilitates its propagation by vascular invasion leading to ischemia. Patients with poorly controlled diabetes, particularly in diabetic ketoacidosis, are especially at risk for invasive mucormycosis. Normal human serum can actually inhibit the growth of mucormycosis, but in patients with diabetic ketoacidosis, the growth of Rhizopus is actually facilitated. The mechanism of this susceptibility can be attributed to altered transferrin binding in diabetic patients, which makes iron more readily available to the fungus. Patients receiving renal dialysis and deferoxamine are also at high risk. Unlike leukemia or bone marrow failure, diabetic ketoacidosis is a reversible condition and hence survival rates are better compared to the bone marrow failure and leukemia in diabetic ketoacidosis patients. This is in short about etiopathogenesis of mucormycosis. Thank you.
Good evening everyone. I am Dr. Danya, working as Senior Consultant in the Department of ENT and Head and Neck Surgery, Rajagiri Hospital. The job vested upon me is to discuss the clinical features of the fatal multisystem disease mucormycosis. Depending upon the site of involvement, mucormycosis can be classified as rhinocerebral, pulmonary, cutaneous, gastrointestinal, disseminated and the forms with uncommon presentations. Mucormycosis is commonly seen in immunocompromised patients like diabetes, chronic renal failure, post-organ transplant recipients, neutropenic patients, acquired immunodeficiency syndrome, etc. Post-COVID, there has been a rise in the mucor cases because of the immune alterations seen in COVID, steroid therapy in COVID, hyperferritinemia seen in COVID, etc. Rhinocerebral mucormycosis is the most common, followed by pulmonary and cutaneous. Now let us discuss the clinical features of rhinocerebral mucormycosis. Rhinocerebral mucormycosis occurs when mucous spores are inhaled via the nose into the paranasal sinus. It can present with nasal symptoms like nasal stuffiness, foul-smelling nasal discharge, blood-stained nasal discharge, mucoid purulent or blackish nasal discharge, facial pain, facial swelling, unilateral headache, exacerbation of headache, etc. From the paranasal sinus, mucor can extend superiorly into the orbit, causing lid edema, orbital pain, restriction of movement of the eye, proptosis, blepharoptosis, or acute loss of vision. It can spread inferiorly into the palate, causing palatal ulcers and eschars over the palate. It can spread superiorly to involve the brain and cavernous sinus. Involvement of multiple cranial nerves and their sequelae can happen. Involvement of brain can lead to altered consciousness, stroke, or even coma. Rhinocerebral mucormycosis can present with general symptoms like fever, weakness, and malaise. So sometimes it is very difficult to diagnose, and high index of suspicion is needed in such cases. Diagnostic nasal endoscopy may be of help to some extent. Diagnostic nasal endoscopy shows pale nasal mucosa or blackish eschars of the nasal mucosa. Turbinates and septum are commonly involved. In oral cavity, palatal ulcers and palatal eschars are seen. Coming to pulmonary mucormycosis, often has non-specific presentation, and sometimes it is difficult to differentiate from pulmonary aspergillosis. Non-productive cough is a common symptom, followed by hemoptysis, pleuritic chest pain, and dyspnea. Cutaneous mucormycosis can be either primary or secondary. Secondary cutaneous mucormycosis is common. It can occur secondary to rhinocerebral mucormycosis or disseminated form. Cutaneous mucormycosis presents with necrotic eschars over the skin, and the palate it presents as palatal ulcer and eschars over the palate. Coming to gastrointestinal mucormycosis, the symptoms are very non-specific. Acute, recurrent upper gastrointestinal bleed are commonly seen. Ileal, appendiceal, and cecal masses are other presentations described. Disseminated forms occur when mucus spread hematogenously to other organs like spleen, liver, heart, etc. So it can present with varied clinical features, and high index of suspicion is needed to diagnose such cases. Disseminated mucormycosis has a fatal outcome. So in mucormycosis, early diagnosis is of prime importance, and high index of suspicion is needed in diagnosis of mucormycosis, and clinical features will help us in coming to a proper diagnosis. Thank you.
Good evening to all. I am Dr. Gifty Zacharias. I have joined as Junior Specialist in ENT. Today I will be talking about radiological findings in mucormycosis. Radiologically, when we are evaluating a patient with mucormycosis, MRI with contrast is the main investigation of choice. Both the brain with PNS and orbit is important in taking a patient with mucormycosis. And other investigations like CECT, that is contrast enhanced CT of PNS, is of least important when compared to the MRI. HRCT thorax also can be taken when we are suspecting a pulmonary involvement of mucormycosis. Common findings while we are looking into a CT or MRI will be involvement of these sinuses and their extension into the nearby structures, angioinvasion, marrow invasion, bone marrow invasion, and perineural invasion. Coming to the MRI, it is considered superior to CT just because the earliest signs of mucormycosis is very well evident in an MRI. It has higher accuracy in detection of involvement of cavernous sinus and perineural involvements. So coming to the various sequences of MRI, there are three main sequences which we consider while taking a case of mucormycosis. First is fat suppressed T2 weighted MRI. Here why we are going for a fat suppressed is normal inflammatory mucosa and fat will be hyperintense in case of T2 weighted MRI. So while when we are suppressing this fat, we will be able to delineate the inflamed mucosa. Then next is contrast enhanced MRI, that is mainly with gadolinium contrast we are using. This will help to differentiate between viable and necrotic tissue, abscess from the secretions, and also helps to know the intracranial extension. Next is diffusion weighted MRI. This shows diffusion restriction in the areas of thrombosis. So those areas where the angioinvasion has happened, there will be a thrombotic, and this will be seen as hyperintense areas in diffusion weighted MRI. So coming to radiological features that we usually see in MRI, First and foremost sign that we usually see in an MRI is black turbinate sign. This is due to the angio-invasion of the disease. The turbinate will be lost. So here you can see in the MRI, like here you can see the normal turbinates as white. The inferior, middle and superior turbinate is being seen in the normal side, and in the other side where the disease is actually there you can see the loss of inferior turbinates and middle turbinates and even superior turbinates. Here it's been shown as a black areas. So next is soft tissue involvement in an MRI. We can usually see that loss of periantral fat, which is the earliest soft tissue involvement sign. Here this is a CT which shows a posterior part of the maxillary sinus. Here you can see the periantral fat, but here in an MRI you can see that this black area will be the area of bone that is being thinned out in the posterior aspect of maxilla, and posteriorly you can see the hyperintense area, which is actually the loss of periantral fat. Next, coming to the orbital involvement, those laminar paprecia will be involved, and there will be extension of disease into the orbit. This can be due to the spread of infection to the valvulus ethmoidal blood vessels, and it will go into the orbit. And there can be pre-septal orbital cellulitis as well as post-septal orbital cellulitis. Here you can see that this is a normal side which shows the orbit with periorbital tissues which is normally seen, and these will be the muscles which is normally seen. This black area will be the maxillary sinus normal part. On the other side you can see that maxillary sinus is there here, but above that you can see the involvement of the orbit. Normal structure of the orbital muscles and all are distorted here. You can see the hyperintense area over these areas. Then here you can see posteriorly post-septal involvement and anteriorly pre-septal involvement of the orbit. This here there will be erosion of the lamina paprecia also. Another sign seen when there is an orbital involvement is guitar pick sign. Here you can see, since the orbit is involved by the disease, the orbit is being changed into a shape of guitar striker. So it is known as guitar pick sign. And in a diffusion weighted MRI, you can see that involvement of optic nerve is there here. There is no further diffusion happening in this space. This is fully thrombotic, and this area is seen as hyperintense, and so we can easily delineate that the disease is there in the neural sheath. Patient may be symptomatically normal with the vision, but since we are seeing the optic involvement with the MRI, especially with the diffusion weighted MRI, we should counsel the patient that there is high chance of losing the vision even after surgery. Coming to the intracranial involvement, this MRI will help to delineate the involvement into the cavernous sinus and also the perineural spread through the various nerves in the skull base. So here you can see involvement of the cavernous sinus. This is hyperintense and normal cavernous sinus is being thrombosed here. And here you can see the internal carotid artery part that also being thrombosed. Next is this is the exit of trigeminal nerve that also is being involved in both sides in this MRI. Coming to the involvement of other blood vessels, here this is very evidently seen that when compared to the other side, normal internal carotid artery is being involved in the right side, and left side it is normal. There is thickening around the internal carotid artery. Here this is again a diffraction weighted MRI which shows the area of infarct in the cerebrum. So to conclude, as there is high mortality in patients with mucormycosis, imaging play a vital role in understanding the nature of disease. Sudden intervention is required for patients with mucormycosis. So, to delineate the extension of disease, we should go for an imaging modality. And the imaging modality of choice in a case of mucormycosis is definitely an MRI. Contrast enhanced MRI with brain and orbit and PNS is the investigation of choice in case of mucormycosis. Thank you.
I'm Dr. Naveen George Kodian. I'm a consultant in ENT and head and neck surgery. Today I will be discussing about the diagnosis and medical management of mucormycosis. Since in the diagnostic part already the clinical things and radiology is already discussed, I will be dealing mainly with the other methods of diagnosis. Among the other methods, the problem with the mucormycosis is early diagnosis is very essential, and this diagnosis, the diagnostic part is always a challenging thing. So, among the other methods other than radiology and clinical things, first one is histopathology. Histopathology is the definitive thing, and the definitive diagnosis of mucor can be made by the identification of fungal hyphae that is typical for mucor in the biopsy specimens. There are mainly three advantages for histopathology. The three advantages are, first one is we will be able to identify the angioinvasion of fungus. Second one is we will be able to differentiate between the pathogenic fungi and whether it is a commensal in the specimen or not. The third advantage of histopathology is that we will be able to identify whether any co-infections, that is with any other fungus, is going on. So histopathology is very important in case of mucormycosis. The second diagnostic modality is direct microscopy. The advantage of direct microscopy is it is a very rapid and it is a presumptive rapid test, so that we will get an early diagnosis in case of mucor. Usually we will be using KOH mount, and as I already told, it is very rapid, and the other advantage is it's very less expensive. And one huge advantage of direct microscopy is that while doing surgery, during intraoperatively for margins, we will be able to send the margins, means pathologists will be able to identify whether there is any involvement in the margins or not. So direct microscopy is very important while we are doing surgery, that is intraoperatively. The third method is culture, and the culture allows the identification to genus and species level. It is also essential for the antifungal susceptibility testing. The major concern of the culture is its very low sensitivity, that is, it can be false negative in 50% of cases. And among the recent molecular methods of diagnosis, PCR based techniques are used. In histopathological samples with characteristic hyphae of mucorales, the application of molecular methods, that is PCR, will confirm the diagnosis. Ongoing researches are focusing on non-invasive methods such as real-time PCR in serology or in urine samples. That is, an ongoing research are going on. Next, we will be just briefing about the medical management of mucormycosis. The proper discussion will be in the discussion part, so I will just brief about the medical management. The mainstay of treatment is antifungal drugs in medical management. The studies proved that early initiation of antifungal treatments will improve the outcome and we will be able to avoid complications also. So that the mainstay is antifungals, as I already told. Along with the antifungal drugs, there are also other important measures. Most important measures is the treatment of uncontrolled diabetes and associated diabetic ketoacidosis, which will improve the outcome. And second one is to stop the steroids and immunosuppressive drugs if we are using any immunosuppressive drugs. And as I already told, the mainstay is antifungals. And among the antifungals, three things we use commonly. One is liposomal amphotericin B, second one is isavuconazole, and third one is posaconazole. Liposomal amphotericin B is preferred over plain amphotericin because of renal toxicity, and its dose is 5 to 10 milligram per kg, and usually we will be giving up to 4 to 6 weeks. And the cost is a little higher, and higher dose will increase the CNS penetration, but there is a chance for renal toxicity in higher doses. And about isavuconazole and posaconazole, Predominantly it is used as a step down drug, and it is also used as a rescue therapy after amphotericin B. And if the patient is having any pre-existing renal functions, we can use isavuconazole or posaconazole. And while giving these drugs, potassium, creatinine and magnesium should be monitored carefully, that is 3 times per week. This is just an outline for the medical management. That is more things about the medical management we will be discussing in the discussion part. That is which drug, when to use, when not to use, or the alterations in dosage depending upon the clinical condition of the patients. All these things we will be discussing during the discussion part. Thank you.
So we would like to present an index case on who had presented with mucormycosis. Probably in that period of COVID, when it started in 2019 to 2021, probably we have come across around 7 cases of mucormycosis. And I would like to present this particular patient because of specific reasons. Anyway, this patient is a 45-year-old, a laborer who used to work in Dubai. He had diabetes which is uncontrolled. He has a history of a COVID-19 infection. And then this patient underwent a minimal FES. FES is an endoscopic sinus surgery that we do for sinusitis. He underwent the surgery in Dubai. That was in, I think it was in early 2019. And then he continued to have symptoms. Later on, this patient developed severe edema of his right eye. He had proptosis. Slowly lost his vision. He had complete arrest of his orbital movements. And then he landed up in his native place, and then he was referred to us. So with this has been a proven case of mucormycosis as per the histopathology report when he was in Dubai. And with the present symptoms, we knew that his disease was progressing, and we had to intervene. Now, this is his diagnostic nasal endoscopy. When we suspect such a case, we first do a diagnostic nasal endoscopy, which is done in the OPD itself. And as Dhanya has mentioned, the typical findings in a diagnostic endoscopy in mucormycosis, this was his finding. You can have a look at his finding. You can see necrotic tissue in his posterior nasopharynx, the posterior nasal cavity. And this is the only finding. But look at his CT and the MRI. We took him for the radiological investigations, and the CT showed an involvement of the entire maxillary sinus with the erosion of this floor of the orbit. Gifty has presented the radiological findings of these patients with mucormycosis, and as she said, MRI is the right investigation of choice for these patients. In his MRI, this is his MRI. The MRI showed, this is the first slide, probably Ajit would like to put in more views on the MRI findings of a mucormycosis patient. But this patient has involvement of the right maxilla, and you can see that his right orbit has been totally replaced with a necrotic tissue. And if you look at the later cuts, if it is posterior cuts, show that the disease is extended beyond the maxilla into the pterygopalatine fossa. I'm sure that you may not be actually remembering these terminologies, but I can actually show you. Can I have the skull, please? Okay, this is just for you to understand. So this is a skull, and it was his right eye which was involved. And the MRI and the radiological findings showed involvement of the right maxilla. This is the piriform aperture, the opening of the nose. And if you can look closely inside, this is the lateral wall of the nose, and then it enters the maxillary sinus into this 6-walled cavity. So it is involving the maxillary sinus, and if you turn this is the posterior wall of the maxilla, and then you can see the pterygoid plates. And when I say pterygopalatine fossa is that area behind the maxilla. So it has extended beyond the maxilla into the pterygopalatine fossa, and once it reaches the pterygopalatine fossa from behind the maxilla, it extends into the infratemporal fossa. This is the infratemporal fossa right here. So this disease had gone laterally from the pterygopalatine fossa to infratemporal fossa, from the maxilla into the orbit, completely involving the orbit, and right into the optic nerve, which actually goes intracranially. So this was the extent of his disease. Whenever we have a loss of vision and total orbital movement restriction, the plan for orbital acceleration has to be thought of. So whenever we have to do an orbital acceleration, that becomes a very difficult decision to make, because other patient in there, it's going to affect them mentally, psychologically. But then it has to be revealed to the patient. So that decision making is a pretty important decision. But then we had to go ahead with it, because the treatment for this disease is an aggressive surgical debridement of the areas involved, along with the medical treatment with antifungal agents at the earliest. That is what we have to do for these patients. So whenever, even when we have a doubt, even when we are suspecting mucormycosis, we start thinking of the surgical debridement and the medical treatment. So for this patient, the surgical planning was to remove the entire maxilla which was involved, go behind the posterior wall of the maxilla, remove the contents of the pterygopalatine fossa, and then go to the infratemporal fossa and remove the area involved. So for that, we have to remove the anterior wall of the maxilla endoscopically. Then we see the posterior wall of maxilla. We drill the posterior wall of the maxilla, reach the pterygopalatine fossa, and then take out the lateral wall of the maxilla to get access to the infratemporal fossa. All this can be done endoscopically. But along with that, we had taken consultation from the oncology. Dr. Subi was always there, and also Dr. Gigi, the plastic surgeon. We have decided to do the orbital accentration also. So that was the plan for the surgical, and also this patient had a palatal involvement. So debridement of the palate was planned, and then the facial-maxillary surgeon, Dr. Binu, was also involved in this patient care, and he had planned the palatal processes to be used immediately after the surgery. And in the second stage, we were planning for an artificial eye for cosmesis after we were sure that the disease progression had completed. And then we had to plan for a palatal reconstruction with local flaps. That was a surgical plan that we had made. This is a video of that particular patient. I have edited in such a way that it's not going to bore you, but I am not very sure how well you would understand this. This is the endoscopic finding. You can see the necrotic tissue. As I said, we had to expose the anterior wall of the maxilla endoscopically. This particular instrument that we are using is called the coblator. The idea is to remove all the mucosa from the nasal cavity to expose the bone, so that we can make the bony cuts and expose the disease. That is the anterior wall of the maxilla. I'll just fast forward it because probably you may not understand what I'm doing. Now this is completely exposing the floor of the nasal cavity. That is the roof of the nasal cavity, and you can already see that some slough on the roof. And here the bone is completely dehiscent. When the roof of the nasal cavity bone is dehiscent, that means that the dura, what you're seeing is directly the dura. So the dura is also infected. That is the dura. And the hole that you're seeing right behind is the sphenoid sinus opening. And then here I'm enlarging the sphenoid sinus ostium so that I can look directly into the sphenoid sinus, which is actually very behind the anterior part of the nasal cavity. It is around 7 centimeters behind the anterior end. Now I am making the cuts in the medial wall of the maxilla right here. And this is the anterior wall of the maxilla being drilled here. And once the anterior wall is drilled completely, you look directly into the maxillary sinus. This is a debrider that we are using to take off all the involved tissue. What I'm touching is the floor of the orbit through the maxilla. It is completely exposed. You can see the slough in the orbit. Now I have reached the posterior wall of the maxilla, and then slowly removing the posterior wall of the maxilla. Here, hey, there is slough again. And as I said, the disease had progressed from that is a pterygopalatine fossa, as I said earlier, full of slough. This is the inferior orbital fissure through which it is extending into the orbit. Now I am thinning out the entire posterior wall of the maxilla. Now once the posterior wall of the maxilla is completely removed, you can see the periosteum of the pterygopalatine fossa and the infratemporal fossa. You can see again slough completely filling these areas, which is slowly removed. And now I am opening up the infratemporal fossa. You can see the fat in the cheek, that is the fat in the buccal part of fat. That is the lateral extent of the infratemporal fossa. Again, the idea of the surgery is to debride every tissue that is non-viable. That is until you see a proper blood supply or a blood vessel which is bleeding. So again, that is a removal of the slough, and once I remove that slough, you can see it looks like a nerve. Yes, it is a nerve. That is the area of the Vidian nerve, and in the lateral aspect, what you are seeing is the branch of the V2, which is a branch of the cranial nerve. And now you see this bleeding from the maxillary artery, which is content of the pterygopalatine fossa. Now once there is bleeding, you stop the bleeding by using coagulator and then using cautery. Once you see the bleeding, you can be sure that your medicines are going to work there because there is blood supply to this area. And finally, the drilling away of the palatal defect and the margins of the palatal defect. So that completes the endoscopic debridement. And then it is followed by, this is again a picture of the palatal defect. This is from the side of the palate and this is from the nasal cavity. And this is the palatal process that we fitted on him on the third day after the surgery. And this was a palatal defect, and it was a palatal flap was done and it was repaired. And this is how it looks, the palate looks today. And this is how it looks now. It's completely healed and looks really well. And again, these are the steps of the orbital excentration done by Dr. Gigi. These are different steps. And so he underwent an orbital excentration also. And then he was put on the medical treatment. As Naveen said, the drug of choice for mucormycosis is liposomal amphotericin B. There are the other forms of amphotericin B, but liposomal amphotericin B is supposed to have the lesser side effects. So this is given as 5 milligram per kilogram diluted in 250 milligram of 5% dextrose, which is given over a period of 2 hours. And we give lots of IV fluids before and after to reduce the drug toxicity. And we monitor the daily serum creatinine and electrolytes. So, and this patient was not financially well off and he had crowdfunding, and he managed to collect some money from his friends. And finally, he had to get discharged because of his financial issues. And so the drug of choice when we send the patient home is posaconazole. So we put him on posaconazole 300 milligram once daily. To conclude, this is a typical example how a teamwork can help in the management of a patient. Involvement of almost all the departments are inevitable in handling such a patient. Since these patients present with rhino-orbital symptoms, most of the time the ENT and the ophthalmologist will be the first to attend to these patients, and hence debridement of the involved areas is the first line of management. They happen to be under our care most of the time. In this patient, Jijiraj, our plastic surgeon, and Dr. Sudhi were instrumental in helping me for the orbital excentration and reconstruction. And preoperative planning in the palatal processes was taken care by our maxillofacial surgeon, Dr. Binu. And without surgeon's team, no major cases happen here. Everyone knows that. And everyone knows how efficient his team is. And again, the medical management and the renal complications that he slipped into were promptly handled by the team nephro. Thank you, Dr. Jose. And again, Dr. Sakri and Dr. James had to be there throughout to aggressively handle the diabetes mellitus. Clinical pharmacology team was there to modify the drug dosage whenever needed. I don't know how many times I must have troubled Dr. Sonia, Dr. Neetu and Dr. Sunita asking them in the middle of the time, middle of the work, to ask for the HPR, KOH mount, cultural sensitivity, etc., etc. And always, I can't forget Dr. Neto, who was not there with us with this case, but was involved in the rest of the series completely. And apart from the doctors involved, I think there are a few more people I have to thank. LG, our ENT coordinator, have been working with me in and out for this patient's care. And apart from being the first surgical assistant, she was the one who literally was with the patient, taking care of the financial and psychological support throughout their admission and even after. Also, without hers, Amal, our designer and editor, the IT, and team relations coordination, this video would never have been possible. Thank you, everyone, for these patients. So it's just a teamwork that helps these patients get back to the normal routine. So these are the take-home messages, and one thing that you need to know, that all fungal sinusitis are not dangerous at all. I mean, whenever there is a tendency, whenever you hear about a fungal disease of the sinus, you think about this invasive mucormycosis. It is not like that. There are, as Shalini pointed out, there are different types of fungal infections presenting in the nose and the paranasal sinuses. So one thing is that all fungal, whenever you hear fungal, remember it is not always dangerous. But then you have to have a high index of suspicion to diagnose invasive fungal sinusitis, because the earlier the treatment is initiated, the better the response would be. So the management is early surgical debridement with medical management, and that increases the survival rate. And as I said, there is a coordination of different departments which helps the patient. So we are open to taking questions. Thank you.